In this lecture, we'll be discussing about hypertensive retinopathy. Now, the definition. Hypertensive retinopathy, it refers to the fundus changes occurring in a patient suffering from systemic hypertension. Okay, so changes in the fundus due to systemic hypertension, that is hypertensive retinopathy. Now, the pathogenesis. The factors that play a role in the pathogenesis of hypertensive retinopathy, they include vasospasm, arteriosclerosis, increased vascular permeability, and raised intracranial pressure. Now, vasospasm. Arteriolar narrowing due to vasospasm is the primary response of increased blood pressure. Now, it affects the retinal arterioles, the choroidal vessels, and the peripapillary choroid. And it is the prominent pathogenic factor in acute hypertension. Okay, so in acute hypertension, the prominent pathogenic factor is vasospasm. Now, arteriosclerotic changes. Now, they cause the thickening of the vessel wall and are a reflection of the duration of hypertension, and hence arteriosclerotic changes are the pathogenic factor in chronic hypertension. Now, increased vascular permeability, it results from hypoxia, and it is responsible for hemorrhages, exudates, and edema. And it is the pathogenic factor in severe hypertension. And finally, raised intracranial pressure, it occurs in malignant or accelerated hypertension. So, under pathogenesis, the four pathogenic factors are vasospasm, arteriosclerotic changes, increased vascular permeability, and finally, raised intracranial pressure. Vasospasm is a pathogenic factor for acute hypertension. Arteriosclerotic changes are the pathogenic factor for chronic hypertension. Increased vascular permeability is that for severe hypertension, and raised intracranial pressure is seen in malignant or accelerated hypertension. So these are the this is about the pathogenesis of hypertensive retinopathy, and all of this affects the retinal arterioles, choroidal vessels, and the peripapillary choroid. Now, coming to the clinical features. Now, we'll be discussing in detail about the chronic hypertensive retinopathy, and we'll be discussing in short about the malignant hypertensive retinopathy. Okay, so the clinical features of chronic hypertensive retinopathy. Now, fundus changes of chronic hypertensive retinopathy, they include: number 1, generalized arteriolar narrowing, and number 2, focal arteriolar narrowing. Okay, so the first is arteriolar narrowing, which is of generalized type and focal type. The third clinical feature is arteriovenous nicking. Okay, now it is the whole hallmark of hypertensive retinopathy, and it occurs where arterioles crosses and compresses the vein. Okay, so arteriovenous nicking, it is the hallmark of hypertensive retinopathy, and it occurs where the arterioles cross and compresses the vein. Now, under arteriovenous nicking, we have three important signs: Salus sign, Gunn's sign, and Bonnet's sign. Okay, now Salus sign, it refers to the deflection of the veins at the arteriovenous crossing. So as you can see in this diagram, this is the point of crossing of the arterioles and the venules, and you can see that the veins, after crossing, there is deflection, and this deflection is known as Salus sign, that is deflection of the veins at the arteriovenous crossing. Now, in Gunn's sign, there is tapering of the veins on either side of the crossing. Okay, so you can see in this diagram, because of the compression by the arterioles, there is tapering of the veins on either side, and this is known as Gunn's sign. Bonnet's sign, the third sign, is banking of the veins distal to the arteriovenous crossing. Okay, so you can see this is the vein, and at the arteriovenous crossing there is banking, that is this phenomenon here. So this is known as Bonnet's sign. So the third clinical feature, that is arteriovenous nicking, it is the hallmark of hypertensive retinopathy, and it occurs where the arteriole crosses and compresses the vein. Now, based on this, we have three important signs: Salus sign, Gunn's sign, and Bonnet's sign. In Salus sign, there is deflection of the vein at the arteriovenous cross junction. In Gunn's sign, there is tapering of veins on both sides of the arteriovenous crossing, and in Bonnet's sign, there is dilation of the veins. So this is about arteriovenous nicking. Now the fourth clinical feature is arteriolar reflex changes. Now the normal light reflex of retinal vasculature is formed by the reflection from the interface between the blood column and the vessel wall. Normally, a bright and thin linear blood reflex is seen predominantly due to the blood column, since the vessel wall is by and large transparent. Okay, so normally when you viewing the fundus, the retinal vasculature, it appears bright and thin, and this is due to the blood column because the vessel wall is transparent. Now, because of hypertensive changes, the we can before discussing that, we can grade the hypertensive retinopathy as grade 1, grade 2, grade 3, and grade 4. We'll be discussing this in a we'll be discussing this soon after discussing the clinical features. But for now, remember, in grade 1 and grade 2 hypertensive retinopathy, there is more diffuse and less bright reflex, and this is seen due to the thickening of the vessel wall. Remember, one of the pathogenic factors for hypertensive retinopathy is arteriosclerotic changes, that is thickening of the vessel wall, and because of this, the light reflex, it appears more diffuse and less bright. So this is in grade 1 and grade 2 hypertensive retinopathy. In grade 3 hypertensive retinopathy, copper wiring is seen, that is a reddish brown reflex of the arteriole is seen due to progressive sclerosis and hyalinization of the vessel wall. And finally, in grade 4, silver wiring, that is opaque white reflex of the arteriole is seen due to continued sclerosis of the vessel wall. So under arteriolar reflex changes, the normal is bright and thin because of the blood column, and the vessel wall is by far transparent. In grade 1 and grade 2, it appears more diffuse and less bright because of the thickening of the vessel wall. In grade 3, there is copper wiring, that is a reddish brown reflex, and in grade 3, there is copper wiring due to reddish brown reflex, and in grade 4, that is opaque white reflex due to continued sclerosis. So these are the arteriolar reflex changes. The other features, they include the superficial flame-shaped retinal hemorrhages. Now, flame-shaped is important. It is characteristic of hypertensive retinopathy. The sixth and seventh clinical features are hard exudates and cotton wool spots. Now, hard exudates appear as yellowish waxy spots with sharp margins, and the cotton wool spots, they represent areas of infarcts in the nerve fiber layer. So the clinical features of hypertensive retinopathy we've discussed are, the first is, just remember the first three R's, AN, that is arteriolar narrowing and arteriolar nicking. Arteriovenous nicking. Okay, so the first arteriolar narrowing is of generalized type and focal type. Then we have arteriovenous nicking, and this is the hallmark of hypertensive retinopathy. We discussed three signs: Salus sign, Bogan's sign, and Bonnet's sign. In Salus sign, there is deflection of the veins at the arteriovenous crossing. In Gun's sign, there is tapering of the veins at the arteriovenous crossing, and in Bonnet's sign, there is banking of the veins. So this is about arteriovenous nicking. Now the fourth clinical feature is arteriolar reflex changes. Now the normally bright and thin blood column is seen. In grade 1 and grade 2 hypertensive retinopathy, there is it is less bright and more diffuse. In grade 3, there is copper wiring, and in grade 4, there is silver wiring. Then the other include the flame-shaped superficial hemorrhages, hard exudates, and cotton wool spots. So these are the clinical features of hypertensive retinopathy. So this diagram depicts this. So we see the cotton wool spots, the hemorrhages, macular scar. These are other signs. Importantly, we discussed the arteriovenous nicking. In grade 3, remember, there is copper wiring, and in grade 4, there is silver wiring, and also the cotton wool spots. Now moving on, in malignant hypertensive retinopathy. Now the fundus picture in malignant hypertensive retinopathy, it is characterized by acute hypertensive retinopathy, choroidopathy, and optic neuropathy. Okay, so this is about malignant hypertensive retinopathy. Now let us look into the grading of hypertensive retinopathy. Now the important classification is the Keith and Wagner classification, and under this, hypertensive retinopathy is described as grade 1, grade 2, grade 3, and grade 4. Under grade 1, there is mild generalized arteriolar narrowing and broadening of the arteriolar light reflex. In grade 2, there is marked generalized arteriolar narrowing, along with focal arteriolar narrowing and Salus sign, that is arteriovenous nicking, where there is deflection of the veins at the arteriovenous crossing. In grade 3, it is the features of grade 2 and copper wiring plus Salus Bonnet's guns sign can be seen, or flame shaped hemorrhages and cotton wool spots and hard exudates. So this is grade 3. And in finally grade 4, it is basically grade 3 features plus silver wiring. So again, the Keith and Wagner classification of hypertensive retinopathy under this grade 1 is mild generalized arteriolar narrowing. Okay, you can remember this by remembering the order of clinical features, that is arteriolar narrowing, arteriovenous nicking, arteriolar light reflex, and finally the 3 superficial flame-shaped hemorrhages, hard exudates, and cotton wool spots. If it's only mild generalized arteriolar narrowing and broadening of the arterial light reflex, it is known as grade 1. In grade 2, there is marked generalized arterial narrowing and focal arterial narrowing may be present along with Salus sign, and also the light reflex is less bright and diffuse. In grade 3, it is grade 2 plus copper wiring, and it involves Salus sign, Bonnet sign, flame-shaped hemorrhages, cotton wool spots, and the hard exudates. And in grade 4 is basically grade 3 plus silver wiring plus papilledema. So this is the grading of hypertensive retinopathy. Now moving on to the management. Now, mild hypertensive retinopathy, blood pressure control is enough. In moderate hypertensive retinopathy, blood pressure control along with assessment of vascular risk factors and control of these vascular risk factors. And in malignant hypertensive retinopathy, small stepwise control of blood pressure is required. So this concludes our discussion on hypertensive retinopathy. We discussed the definition, the 4 pathogenic factors, that is vasospasm, arteriosclerotic changes, then increased vascular permeability, and the raised intracranial pressure. Then we discussed the clinical features. Remember, arteriolar narrowing, arteriovenous nicking, arteriolar light reflex changes, then the superficial flame-shaped hemorrhages, the hard exudates are the cotton wool spots, right? Then we discussed the grading, the Keith and Wagner classification, grade 1, 2, 3, and 4, and we discussed the management. And in this, the most important is the clinical features of hypertensive retinopathy.